but I have spent, I guess, since 1994, so it's 20 years now, doing research in long-term care facilities and looking at drug interventions. Hey, I found the button, that's good. So I've had research support from various drug companies over the years, as well as honoraria. Not in a long time, though. The times have changed, and we don't really do that anymore. And the research that I'll talk about that we have done has all been supported. We've been lucky. We've had consistent 20 years of the peer-reviewed funding supporting our research, which just shows that there is an interest in this area. So I thought what I would do today is just go over the current recommendations for pharmacotherapy of these neuropsychiatric symptoms. You saw the different definitions. I'm going to call them NPS, or neuropsychiatric symptoms, and just be aware of some of the recent research findings. This is important because we know that medication use in the long-term care facility is very high, and I'm showing you research that's actually from Ontario long-term care facilities. David Kahn et al. Did this out of Baycrest. And we know that antipsychotics and benzodiazepines are used by 10 to 30% of people in long-term care, 20 to 30%. Antidepressants a little bit less, in 10 to 30%. And we know that 30% of long-term care residents with dementia receive cholinesterase inhibitors. And you can see that it's probably not just random, but I quoted some of our panel members who actually contributed to this research. And they're very challenging to treat. We have people with advanced age, a lot of frailty, and they have a lot of multiple medications that they're already using that you have to take into consideration. Current recommendations. First, I'm a psychopharmacologist, but I always have to start by saying we always want the non-pharmacologic interventions in place. So even though I'm talking about drugs, we're assuming that we're already at the next step, and that's why I presented after Dallas, speaking about non-pharmacologic interventions, because that's the order it's supposed to go in. We have to identify target symptoms, then choose a medication looking at specific contraindications, as well as any drug interactions that they might have. And then it's also a matter of continuous reevaluation. These people have a neurodegenerative disease. Their brain is going to change over time. So even if they've responded to one drug at a point in the past, their brain is not going to be the same a year later. So you have to continuously reevaluate and keep in mind that this is a degenerating brain. So I use the word responsive, but I guess that's a problem now. But let me just qualify that and say that I'm saying they're drug-responsive behaviors, because we have to keep in mind that some behaviors are appropriate for drug therapy, we'll call them appropriate, and others are not. So the drug-responsive behaviors, if you look down that list, I wonder if I can get the, how do you get the, oh, there it is. Laser. If you look down this list, you can see that they pretty much mirror what we think of as psychiatric diagnoses. So it's agitation, anxiety, depressive symptoms, apathy, delusions and hallucinations, verbal and physical aggression, and sexually inappropriate behavior. And on the non-responsive side, we have all the other things like wandering and inappropriate urination, inappropriate dressing and undressing, hiding, hoarding, tugging at your restraints, pushing wheelchairs all over the long-term care facility, and persevetive shouting and screaming. That's not to say that these aren't important, right? We all know the patient who has the persevetive shouting and screaming, and by the time you've had a whole day of that, you're kind of on this side where you're having some of these psychiatric symptoms yourself after 8 hours of banging and screaming. So there are other interventions for that. All right, so an evidence-based approach. I'm going to just summarize here on one slide for you the recommendations from the 4th Canadian Consensus Conference on the Diagnosis and Treatment of Dementia. So they get people together from all over Canada, and actually Dr. Herman and myself with David Hogan just in 2012 did the pharmacologic update. So the first-line drugs that we think of are still atypical antipsychotics. And in these guidelines, if you read them, we're very careful. We put in all the caveats and say, you should have the non-drug interventions in place. It has to be distressing to the patient or distressing to the caregiver. Specifically for the atypical antipsychotics, they have to be used judiciously. We recognize the importance of mortality. But with all those caveats, it still has to be said that these are the drugs that for agitation and aggression and psychotic symptoms have some of the strongest evidence supporting their small efficacy, right? And also first line Citalopram. Second line, we have anticonvulsants, and new to the recent update, we now specifically don't recommend valproate, and Dr. Herman and I did actually run a small study in the long-term care facility. And, you know, the minute, so I'm the non-clinician, the minute Dr. Herman would walk out of the building, we would have someone with a side effect. And nursing would be calling me, and then I would have to try and find someone to cover for Dr. Herman. So it wasn't popular with nursing, and it wasn't popular with the researcher either. And in the end, we don't have efficacy. So not valproate. There's trazodone and SSRIs, and then the cholinesterase inhibitors and our memantine on the second line. And third line would be some of the medications like beta blockers, benzodiazepines, and buspirone. And I just wanted to organize these for you and have this as a slide that you'll be able to download, just putting them into medications for specific target clusters, because those are first, second, and third line, but we know that for different behaviors, there are different randomized controlled trials that have used that behavior as an outcome. For example, for severe agitation and aggression, antipsychotics and antidepressants have evidence. They're on the first line, and then as a possibility, maybe the anticonvulsant carbamazepine or oxcarbamazepine. Apathy, we have cholinesterase inhibitors that are usually given for the dementia itself in about 30% of patients, but I'm going to show you some new evidence for stimulants. For depression, the antidepressants, you can see, are not bolded because there's been a lot of evidence that they don't work that well for depression. You'd think they would, but DIADS 2, the most recent study, showed that there isn't a good response to antidepressant therapy compared to placebo. And for severe psychosis, antipsychotics and sometimes cholinesterase inhibitors, and for sleep, benzodiazepines, but we really only have a second-line treatment for sleep. And of course, with all these, as I mentioned, all the caveats that they have to be important, short-term use, judiciously used. So let's move on to the more fun part, what's actually new. There's more evidence for aripiprazole. Aripiprazole is an atypical antipsychotic, and when we first wrote the guidelines, it hadn't actually been, it had just been approved in Canada, and now there's evidence for its use in long-term care. But just to show you an example of this, this is Stream et al.'s most recent study. So this is actually done in long-term care facilities with people with Alzheimer's disease and psychotic symptoms. So this is probably similar to the age and proportion of people that you would see in your long-term care facilities. They're about 83 years old, and the majority of them are female. They're randomized to placebo or aripiprazole, and I gave you the dose there. So this is the population in the study design. To focus on the results, they found decreased neuropsychiatric symptoms, but they found them in both groups. So there was not a significant difference in their two co-primary outcomes. They decreased both in psychotic symptoms and in that global rating, clinical global impression. They did find in additional tests done after the study an advantage for aripiprazole when you had a greater severity of psychotic symptoms. So that's kind of with our guidelines that you do have to have severe psychotic symptoms before medication should be considered. And they found that aripiprazole did benefit agitation, depression, and caregiver distress. So those were secondary outcomes, though. And of course, they found that you had more somnolence with aripiprazole. And this is a trial that we ran, as Dr. Herman mentioned. We've spent a lot of time doing this research. We have the ADMET trial, and this was based on research that showed that the dopaminergic system was linked with apathetic behaviors. It was a 6-week randomized controlled trial. We found a trend for apathy, but for one of our, only a trend for our primary. For our secondary outcomes, though, we did show a benefit for apathy, and we could also pick it up on clinical global impression. And this trial just came out very recently. This is the CITAD trial that came out last week. And this is an important one because it shows that citalopram, the antidepressant, can actually have a benefit on agitation. So in the CITAD trial, citalopram for agitation in Alzheimer's disease, they had Alzheimer's disease and clinically significant agitation, and they looked at about 186 people and randomized them to either citalopram or placebo. And this was a successful study. They found significant benefits on agitation, They used the NBRS, or the Neurobehavioral Rating Scale, as well as clinical global impression. So that means the clinician can tell the difference between who's on the drug and who's not on the drug by, instead of doing a very sensitive scale, by just using their clinical global impression. They found significant benefits on agitation, total NPI, so all the neuropsychiatric symptoms, and caregiver distress. No difference on agitation on their other scale, activities of daily living, or they found no decrease in lorazepam rescue. And because it's a drug, significant worsening of cognition and QT interval prolongation. And I should point out, though, that even though we have this evidence, it was only done in outpatients to date. So this is not a long-term care facility trial. But it does give us hope in the long-term care facility. And then finally, another way of doing research, of course, is to withdraw medications. So this is a withdrawal trial. This is Alzheimer's disease patients. They were all in long-term care, randomized, placebo-controlled discontinuation trial. They either continue the antipsychotic, and they had specific antipsychotics that were in this trial: thioridazine, chlorpromazine, haloperidol, trifluoperazine, or risperidone. The majority of their patients were actually on risperidone or haloperidol, and they could either be continued or switched to a matching placebo. And they looked at mortality over 12 months. So survival at 12 months was 70% in the antipsychotic continuation group compared to 77% in placebo. So it just reminds us that we do have to be aware that even though that these are first-line drugs, there is an increased risk of mortality for antipsychotic continuation versus placebo. And then discontinuation of antidepressants, a double-blind randomized placebo-controlled trial. They discontinued SSRIs in non-depressed. Again, these are real nursing home patients with dementia and neuropsychiatric symptoms. And they actually found that discontinuation, despite the fact that we've had trouble demonstrating that it helps with depression, when you discontinue, you have a significant increase in depression. And this was as measured with the Cornell scale for depression and dementia. There was a trend for a difference in overall neuropsychiatric symptoms, but it didn't reach statistical significance. And the scores for agitation and psychosis were similar in the group. So in summary, we know that neuropsychiatric symptoms are very common in long-term care. We have clinical practice guidelines. However, we still have a lot of challenges in pharmacotherapy. In the literature, I showed you an update from 2012 to 2014, and it kind of only took me 5 slides. So that reminds you that there are a few trials that actually target neuropsychiatric symptoms. And even within that group, there are even fewer trials that target long-term care facility patients. And I think it's important that we actually have research in these patients because they're not the same as your community-dwelling earlier Alzheimer's patient. So what do we do to move forward? First of all, we have to understand neuropsychiatric symptoms better. We have to know the phenomenology. Neuroimaging can help us target drugs, biomarkers, and do pharmacologic challenge studies. And to optimize pharmacotherapy, we have to do this translational research. We have to look at these drug targets. We have to characterize response. And I think importantly, we have to have rigorous randomized controlled trials that are specific to a neuropsychiatric symptom, so specific target. A lot of times they just look at overall neuropsychiatric symptoms, but we want a specific target. And we want them to be in patients who are in long-term care facilities because we know those patients are different. So that the next time I come and I show you clinical practice guidelines, I can actually show you evidence that's all being done in long-term care facilities. So I think Dr. Herman has a couple more slides to present, and then that's it.